Well, good evening. Welcome to the third session of Delaware Mini Medical School for 2022. My name is Tim Gibbs, your co-host for this evening, along with Dr. Kate Smith. I direct the Delaware Academy of Medicine, Delaware Public Health Association, and we are delighted to have you with us here this evening. You know, Delaware Mini Med is a partnership between the Academy of Medicine, Public Health Association, and our colleagues at ChristianaCare. Last week, this evening's speaker, Dr. Bradszandela, and I were interviewed about Mini Medical School. One of the points we made in an interview, I want to repeat to you this evening. Regardless of your age, Mini Medical School is a unique opportunity for you, the students, to interact with some of the finest healthcare professionals in the country in a non-clinical setting, not unlike learning from and chatting with a space shuttle astronaut or a race car driver, just not when they're doing their thing. For those of you who are middle, junior high, high school, and undergrad students, we sincerely hope this will kindle your interest in health science related career. Our work in the field is as rewarding as it is challenging, and heaven knows the last couple of years have been very challenging, and we need to grow the next generation of caregivers of all types. With that bit of housekeeping, let me get on to the word of the day and our presentation. And I need to clear some notations off of the screen real fast. All righty, very good. There we go. Not quite sure how that's happening. Okay, so we're on the third session today. This is sports medicine with Dr. Bradszandela. Some of those little odds and ends, please change your name to your username to your full name that you use to register. Click participants, hover over your name, choose more, and then click rename. That way we can make sure we know exactly who's here. Remain on mute throughout the presentation. Questions will be answered at the end. To ask a question, either put it in the chat or raise your hand, and Dr. Smith will unmute you when that time comes. The sessions are being recorded and they're available at delawareminimed.org after each session, along usually with the presentations. Attendance will be taken in the following manner, and you need to only choose one of these. Participants attending via Zoom may enter their full name and school if they're a student into the Zoom chat by 7:15. So that's coming up here in about 10 minutes. Participants attending a session by phone need to email Dr. Kate Smith, that's ksmith@delamed.org, before 9 p.m. this evening with the code word of the day, and I'll tell you that in a minute. And at the end of the 6-week session, a survey will be sent out to all members. That survey will be taken by 6 p.m. on Friday, April the 1st of this year in order to receive a certificate and credit. In order to get that certificate, participants must have attended all 6 sessions. And we are sorry, but for fairness to everybody else, we do need to remain fast to that rule. And of course, you need to complete that survey. So on to Dr. Bradszandela. Hold on just for a second, please, and let me zoom this open. Dr. Sandella joined ChristianaCare in July of 2012 as the program director for the Sports Medicine Fellowship. During his tenure at ChristianaCare, he has served as the lead for musculoskeletal service line, currently is the physician executive for ambulatory consultative specialty service line, and associate medical director for consultative specialties in the Center for Virtual Health. In addition to his responsibilities of ChristianaCare, in the fall of 2013, he joined the University of Delaware as an assistant team physician, providing care to student athletes in the student health clinic and on the sidelines. And how cool is that? Prior to joining the system, he attended the Philadelphia College of Osteopathic Medicine, or we call that PCOM, completed a residency at ChristianaCare Health System in Family Medicine, and continued onto the Sports Medicine Fellowship of South Bend Notre Dame University in Indiana to complete a fellowship in primary care sports medicine. Dr. Bradszandela is a certified in family medicine and sports medicine. Brad, you and I have known each other for a little while, and folks, the code word of the week is rain. I think when Dr. Smith created that code word, it was in fact probably raining. And I do believe we're over to you. I'll stop the share and you can start.
Tim, thank you so much. Thank you all for joining. It's such a pleasure to be here. I'm incredibly excited. So this is great. Tim, can I pull up some slides? Is that okay? All right. Okay, and I'm sure you guys can see my slides. So that was a great introduction, and thank you so much. Let me just start off by saying, it's such a pleasure to come and have a chance to speak with everybody this evening. I think I have the greatest job in the world, and I'm incredibly excited to share with you a little bit about sports medicine. I'm actually going to debunk kind of the term of what sports medicine is and tell you that it's actually a little bit grander than it first appears, and share with you some stories and some of the medical side of sports medicine. So please, I'm pretty open and informal. So if there's any questions, feel free to interject, or you can hold them until the end, as Tim recommended, and then we can go. So as we start off, this is what I do. And this is actually why my job is pretty cool. So it's a short little video. So take a look.
One section was be arresting that. Not arresting that. So now instead of 3 up there, they get 2 and a third.
So I'll play that again for everybody, because I've shown this video a couple times, and everybody is usually watching the wrong athlete on the field. So take a look at this again, and then I will walk you through exactly what happened. Oh, shoot. Oh, sorry. So right there where I was trying to stop it, and I'll play it again, was what happened was the person who was filming this video is actually the mother of the batter. And that's why the batter is centered, not the catcher. What happened was, and I'll talk over it while it's going, the batter actually foul tips the ball off of his bat, and the ball then ricochets directly into the catcher's chest. These are high school level athletes. That catcher is actually 17 years of age. And what happened to him was, this is actually one of the rarest things that we see in sports medicine. And I actually happened to be there for this athlete. This was not a video that I pulled off of the internet. What happened was that this young man sustained a condition that's called commotio cordis. And what that is that's when a ball, a projectile, hits somebody in the chest, and usually it's a young person, usually in their teenage to maybe 20, 21 years of age, and it's a specific formula. What happens is it has to be somebody who's young enough where their chest is still a little bit compliant. It just kind of flexes a little bit. They're not old and they're brittle. He's pretty compliant, and the ball hits him, and it hits him at the exact moment when his heart is going to recharge so it can beat again. And what happened is it hits it, and it's like it tripped the circuit, and it caused an electrical interruption. And then what happens is that instead of going into the typical lub-dub that the heart does, it actually goes into a rhythm that's called ventricular tachycardia, which is a very fast, more like a thump, 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 thump. And then it degrades and worsens into what's called ventricular fibrillation, which is a chaotic rhythm, which is like all over the place. It's like bump, 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 bump. And what that does is that is actually not compatible with life. And this young man here, he actually, he required us to shock him. We actually had to come down and, when you're in, you hear about the AEDs, we actually had an AED on our possession, and we put the pads on him, and we were out in the field, and we were able to shock him, and we got him back, and he lived, and he did great. And he actually went on to play baseball in college, and his mother went to every game with her defibrillator in hand, not because he was going to have another one, because it's not a hereditary thing. It's not something that will follow him. It was just a complete fluky incident. But this is why I have a job. Besides working in an office, part of my office is out in the field as well. So, emergency room doctors are in emergency room, and cardiologists are in doing cardiology things and catheterizations. I get to interact with healthy, athletic people, and sometimes people maybe who aren't super athletic, but they just want to be physically fit or get involved in running or whatever. I get to work with them where they're comfortable and where they want to do sports or where they want to do their activities. And this is one of the situations. So what is sports medicine? So sports medicine, in my opinion, is actually a little bit of a misnomer. When people hear sports medicine, they think about that last person I just showed you in the video. They think about a high school or a college age, or maybe even a professional athlete who gets injured and who is playing a sport and sustains an ankle sprain or a knee problem or whatever. And those are a lot of the patients we see. But we also see a lot of people who are just trying to be active. Maybe they play basketball on the weekends, or maybe they want to keep up with their grandchildren and run around, or maybe they want to do an activity. So we actually at Christiana, we've rebranded it. We call it sports medicine and lifestyle medicine, because what we're trying to do is we're trying to take care of everybody and anybody who wants to be physically fit or well or move or do something and be happy. And then the other part of my job is that I get to work with people to return them to either their sport or their work or their lifestyle as quickly and as safely as possible. So that way, hopefully they won't get hurt again. And if necessary, to protect them so they can keep doing whatever it is they want to do. So there's a couple principles that I try to live by whenever I'm interacting with some type of an athletic or healthy person, is that I think about my job is to restore their function, to maximize their function, and to preserve their function. And these are kind of the tenets that we live by for sports medicine. So, if somebody gets hurt, their function has been impaired, my job is to restore it. I have people who want to get better. Maybe they want to run a faster mile time, or they want to qualify for a marathon, or they want to swim an extra mile. So my job is to try to maximize their function and work with them to try to maximize their function. Or maybe they're getting a little bit older in age and they just want to be able to play golf, or they want to keep playing tennis or pickleball. So my job is to preserve their function and to keep them physically active. So I get to deal with people and kind of hit them right where they want to be. And it's really rewarding, because a lot of individuals, when I have high blood pressure or diabetes, it's not very tangible sometimes. But this is very, very physical. People know it. People might have pain. And I get to work with them and get them either out of pain or get them better functioning and get to keep working with them in that regard. So who do I see? What kind of patients? I could see somebody as young as 10 or even younger with knee pain, or maybe a teenager with shin splints from running, maybe a 21-year-old college student playing soccer, or a 39-year-old weekend warrior who played minor league baseball and wants to keep playing, 40-year-olds playing, whatever, with foot pain, or somebody a little bit older, maybe doing surfing, or maybe a 50-year-old who, what we call an urban athlete. Maybe they're a construction athlete and they have to paint, they have to work overhead, they have to do something that maybe hurts their shoulder. Maybe it's a female who competes in dragon boat racing at the age of 60. That's her retirement activity. Or maybe it's somebody who's even a little bit older, 73 years old, and a grandmother who just wants to be able to keep up with her grandkids, not get tired out before they do. Those are the types of individuals that I get to work with. So it's a whole swath of people, and everyone comes in with a unique story, and every one of them is super fun to engage. So this is the hallmark of everything that I do. So, I talked about the functions. So a lot of this is all about health promotion. So this is, we talk a lot about trying to be proactive and trying to help people get hold of their health. This is all about health promotion. I get to talk to individuals about, the right things to eat, maybe talk about their bedtime, talk about their activities they want to do. How do I promote a healthier individual? How do I promote somebody to keep them as healthy and as happy as possible? I talk about disease and injury prevention. So this is classically what most people think about when they think about sports medicine. Somebody gets hurt, they come and see me, I evaluate them, I get to take care of their injuries and rehabilitate them and fix them. And what I did is I have a whole case that we're going to go through. And that case is going to actually kind of walk you through exactly what I get to do on a daily basis. So you'll actually kind of learn the ins and outs of the trade of sports medicine. The hallmark of it is evaluation. And this is actually one of the most fun parts my field is, I think, one of the biggest that deals with anatomy and physiology and taking a look at the body and understanding how the body interacts and how it's all of its pieces come together to create a moving system. I get to come up with treatment plans, and usually I do this in a team formation where I will work with physical therapists and nutritionists and strength and conditioning coaches and all different kinds of allied health professionals to come up with a plan that's going to fix somebody and get them back to the function that they want to be. Probably the hardest thing I do is return to play decisions. The one nice thing about my job is people get hurt typically when they're doing things that they enjoy, what they love. And I have to often settle a person down and allow them to heal. But it's exciting to try to push the limits a little bit and do things where we can try to protect them or put them in braces or do something that's going to allow them to get back a little bit sooner, especially when you're dealing with an individual that is maybe a senior, and this might be the last time they step on the field to play soccer or basketball on a court. Or maybe you're trying to get somebody back in time for the playoffs, or maybe somebody's getting ready to take their first vacation and they're having a hard time walking and they're about to do a ton of touring of a city and their knee pain is killing them. So I get to step in, but part of it is trying to tell them how aggressive we can be. And sometimes that's a little bit challenging. And then finally is exercise prescription. And this is what I use for medicine. I don't write a lot of prescriptions for people to go to the pharmacy and get a drug. I write a lot of exercise prescriptions, and I tell them what to do when they go to the gym, or I tell them how much walking they should be doing for how many minutes and where they should get their heart rate elevated to and how they should be moving. So this is my tool. I only write for maybe 4 or 5 medicines an entire week or a month, but I write a lot of exercise prescriptions. So that's where I get to interact with people and give them some guidance. So I wanted to take a moment, and I was watching as the list of people were coming in, and it was really exciting to see so many people in high school that were on the call today. So I thought I would just really kind of give you guys a snapshot of how I got to where I'm at. So if anybody has any desire to do this, this is you can see at least my path of how I got here. So I got interested in medicine when I was in high school. I actually started working after playing sports. I started working as a student athletic trainer and start to get very interested in the other side of athletics and taking care of people when they got hurt. And that was kind of my introduction. So when I went for my undergraduate degree, I actually sought out a place that I could further my training and become a certified athletic trainer. And, I'm sure many of you have worked with athletic trainers in the high school or whatever setting it might be. But, the athletic trainer is very close to the pulse. They're usually with teams on a daily basis, or they're available all the time. And it was super exciting work. And I got to really see how athletes function and how they work. And after I got done with my undergraduate degree, I actually worked in the field for 5 years as a certified athletic trainer. And I worked in high schools, and I worked around college athletes, and I worked in doctors' offices, taking care of individuals as an athletic trainer and being the extension of the medical team into the field. So, I started off by showing you a video of me covering a baseball game, but as an athletic trainer, you're there for all the games and all the practices, and you're doing all of that. And that's what I did. For me, though, I wanted to do more. As an athletic trainer, it was great, but I thought I had more to give, and I wanted to get more involved in my athletes' overall health, and not just be there for when they sprain their ankle, but also talk about promotion, health promotion, and talk more about the things that I really, really loved. So I decided to attend medical school. And as Tim pointed out, I went to PCOM. So I'm an osteopath. So if you're familiar with the difference, I get to use my hands, and I get to work with people with my hands. And that to me was a natural fit from an athletic trainer to an osteopath. But I have tons of colleagues who are MDs. They're called allopaths. And it's almost exactly the same. It's just one extra tool in my bag. And then I actually came down to Christiana. I grew up in Pennsylvania. I came to Christiana to do family medicine. I at the time, I didn't even know that sports medicine was a specialty. I thought that, all right, family medicine docs see a lot of people come into their office on a day in and day out basis. And this would be a great way for me to get involved in seeing people who are active, but also who might get hurt. Maybe they sprain their ankle or their knee, and I can get involved in that way. And then while I was in residency, I found out about sports medicine, and it was a natural fit. It was a great fit. As much as I love surgery, I didn't want to be a surgeon. I didn't want to be in that. I wanted to have a little bit more of a different relationship with my patients. But the sports medicine thing was great because it allowed me to do some primary care as well as specialize in sports. From there, I went on to Indiana. I left the area and I went to the middle of the country, so that way I could learn just in a different setting. And I was fortunate to go to Indiana at South Bend and work with some hospitals out there, but also Notre Dame University. So I got to see athletes and athletics at the pinnacle, at the highest point, in my opinion. And I got to cover football and basketball and women's basketball and soccer and all different sports at that level, and saw some really high caliber athletes. And that allowed me then to come back to the East Coast, and I worked up in Philadelphia, and then I came to Christiana, so that way I can continue. And then I was fortunate to keep working and get to work with the University of Delaware and things like that. So that's kind of my journey about how I came to be at this spot, and I've continued to do it to this day. I'm still practicing sports medicine, even though I've taken on some additional responsibilities in the system. I still get to do sports medicine. I still get to work with people who are trying to be active, and I still get to do the lifestyle piece and really keep people well and prevent them from getting hurt. What I wanted to do now was get into a case. But Tim, before I keep going, I wasn't sure, did you guys want to take a break? Do we need a pause, or do I just keep going?
This is Kate. You can keep going. I think we're good.
Great, Kate. Thank you. So I thought this would be a great way to tell you a little bit about how sports medicine, this is a typical walk in my day. And I thought, because we're in March and we have March Madness on the mind, that I would do a basketball case, and I would center it around knee pain. So you're me at this point. So I'm going to walk you through exactly how this happens. So you're covering a college basketball game, and a 18-year-old female freshman, she's in the middle of the game, and I apologize, I don't have a video for this one. She injures her knee. She's bringing the ball up court. She's a guard, and as she's bringing the ball up, she's kind of trotting, running, walking, that trotting, and she pivots so she can pass the ball. No contact. She doesn't bump into anybody. She doesn't hit anything. but all of a sudden that sudden direction change, and you watch her and her knee kind of buckles and she feels a pop and she has got pain and she drops to the ground. Now, part of the importance of sports medicine is sometimes seeing the injury itself, and you're seeing the mechanism. And what you'll find is that a lot of your evaluation can come in that moment, because you start to put the pieces together and you said, all right, here's an individual who there's something traumatic happened, but there was no contact. She didn't get knocked to the ground. She didn't get tangled up. There was nobody, she didn't get hit by anything. So you start to play in your mind about the mechanism here. And the mechanism and seeing it is so critically important. It gives you a great insight. What you find is when you're dealing with patients, they're not always the greatest historians. They can't always tell you what happens, especially in the middle of a basketball game when there's so much excitement and there's activity, and maybe they're going for the winning basket at that moment in time. Things get blurry. People can't remember. They also have pain, and maybe they don't remember the exact episode because they had a lot of discomfort. So you seeing it is equally important. That's why the sideline is the extension of my office, and being able to be there and be part of the action really is part of it. I joke that I said that my, Christiana actually pays me to watch sports, but it's true. I mean, that's part of my job, is to actually see these things and be there when they happen. So I see this, the athletic trainer goes down, I go down. So I'm there to try to help and be there. And I watch the athlete kind of hobble off the court. So in my mind, I start running the anatomy. I start thinking about where I'm going to be pushing on this person. And this is what you will do, is because you'll have anatomy, and you will know, and you'll be able to picture in your head exactly what you're talking about here. So you think about the anterior, the front of the knee. What do you have there? You have, underneath the skin, there's that bone, that patella, and that's held in place by two tendons. And you have your patella tendon. That's the one, that they always check the reflexes on. And then you have your quadriceps tendon, which is right above it. But primarily, we're talking about patella tendon. The other two bones of your leg is you have your femur, your thigh bone, and your tibia, your shin bone. And they make up the three bones of the knee. So, okay, you thought about our anterior and the bones. You think about what's in the back of the knee, and you're like, okay, I know they have your calf muscle, which is, it's called your gastrocnemius. There's some vessels back there, and maybe a nerve, but the popliteal vessel. So you start to think about that a little bit. And you're like, okay, if she's bleeding, I got to think about the popliteal vessels, and those are pretty good sized vessels. So I need to consider that if I see any blood. I think about the inside of her knee. That's the medial part. We think about that medial, like the midline. And I'm like, all right, what's on the inside of her knee? I'm like, well, okay, she has that medial collateral ligament. That's her MCL. You've probably heard of that before. And then on the outside, its counterpart is the lateral collateral ligament. Those are the two hinge ligaments. Those are the ones that kind of keep the knee from going side to side. And then you have the cartilage, or the meniscus. And you've probably heard of those. Those are the bumper cushions inside. And then deep inside, you have a couple more ligaments. That's where you have your ACL and your PCL, your anterior cruciate ligament, your posterior cruciate ligament. So you've kind of reviewed your anatomy, and then when you get down there to check her out, you'll know exactly where you're pushing. And you'll go through the same process every single time, and you'll palpate the same structures on every human being. And you'll go through, patella tendon, blah, 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 and right through it. Here's those ligaments I just spoke to you about. So inside, if you look deep inside the knee, that's where your anterior cruciate ligaments are. Now, the difference is ligaments connect bone to bone. They don't contract. They don't stretch. They're not strengthening. They don't move. All they do is they're static stabilizers. They hold one bone to the other bone, and their job is to keep the bones in place. They're like the check reins that keep things from drifting all over the place. So you have four of those in the knee. We talked about them. And then we talked about the cartilage. And then your last piece of cartilage, you have the meniscus, those are bumper cushions. And then you have this other thing, it's called articular cartilage. And that's the cartilage that lives over top of the bone itself. And that's when people get arthritis, what they do is they're wearing through the articular cartilage. That gets roughened. You can sometimes get little potholes in there. That gets beat up. And underneath the cartilage is the bone itself. So you may have heard the term bone-on-bone arthritis. That means you've worn all the way through the cartilage. And that causes a lot of pain, and that can be very, very painful. The cartilage is like your protective mechanism. It's like your elbow pad. Now, every joint is like this. This is not unique to the knee. Now, they all don't have all the same ligaments, but they all have a lot of the same features. They all have cartilage. They all have ligaments that hold the bones together. They all have muscles that make things move, and they all have tendons that attach the muscles to the bone and the muscle to the muscle. So even though we're specifically talking about knee, these anatomy features are present throughout. So you can kind of, you can apply this to everywhere. So you've done your anatomy work. So you get down, and now you're going to do what's called your sideline evaluation. And this is that first chance you have to make a return to play decision. Because now you have somebody who exited the game because she was hurt. And now you're being asked, can she go back in the game? That's always the decision. So, if you watch the NFL, you see people, now they go off on the sidelines, they go underneath the little tent that they pull up, and then they evaluate them. And sometimes you see them run back out, and sometimes you see them run into the locker room, or sometimes you see them just run and sit on the sideline. But that's your chance. So you do your evaluation. So you go through your whole anatomy, and you're asking some more questions. You're taking more of a history at this point. That's the question asking part. And she tells you that she's having pain, and the pain's a little bit more severe now. And she doesn't think she can return, and it makes your life easy because you're like, all right, well, that takes the pressure off of me. I don't have to tell her that she can't return, but you were going to do that anyways. You knew that she had so much pain and she just couldn't protect herself that you were going to tell her that she couldn't return to the game. So you sit her down, you put some ice on her leg, and, you kind of monitor. Maybe you put an ACE wrap on her. You give her some crutches to get home. You don't think anything's broken, so you don't think she's got to go to the emergency room that night. So you just you let her go home. But what you find out is, and you'll find this out tomorrow, we'll get there in a second, by the time she got home, about a half hour later, so all in time-wise, it's maybe been about 2 hours from the time she got hurt. Now she tells you that her knee is big and swollen, or she's going to tell you that tomorrow. And that came on later. But regardless, she did her icing as you asked her to do. She kept it elevated. She tried to stay off it for as much as she could, and she tried to take care of it. But she didn't have a great night. So because, you're in the office tomorrow, and this is an athlete that you take care of, you offer her to come in to see you the next day in the office. And this is often exactly how this plays out, is you see him the next day. Because what you've also done is you've also done something good for the healthcare system and society. Is, you didn't send her to the emergency room, and she didn't need to go to the emergency room. So you're able to keep her out of a 3-hour wait, and you're seeing her the next day. And it's also comforting to your athlete because she knows you, she trusts you, and she knows that you're there to take care of her for her best, the best interest of what she's got going on. But what this does is this gives you, now you're on your turf. You're off of her turf, you're on your turf now. And now you can kind of control everything. You can control the visit, you can control the time, you can control what gets done. There's not fans that are looking over your shoulder. There's not a coach that maybe is asking you if she can go back in. You're on your terms, and you can take your time and get a much more detailed history. So you ask about the present injury, and the present injury that's what happened. And you ask her to recall, to the best of her knowledge, what does she remember? And she might be able to tell you pieces, but once again, you were there, you saw it, so you could fill in the rest. But you're asking about, I was coming up and, I tried to pivot to pass the ball, and my foot got stuck, and I twisted, and I felt a pop. She might tell you, I felt a pop. The other thing she might tell you, and some of the other really important questions that I ask is, did you feel anything mechanical? What I mean by that is, did you feel like your knee could give away? Did it feel unstable? Did it feel weak or loose? Or did it feel like it could get stuck or got caught, like something was snapping or catching, which made it hard to move? Then you can take a previous history. You can ask her about injuries that happened to her in the past. she might tell you, hey, I hurt my knee a year ago, or maybe I hurt my other knee and I had a very similar thing happen to my other knee. And, that helps because you can kind of think about, is there anything, maybe her biomechanics and her body, the way that she's built, predisposes her to an injury. So you get that previous history. You do a full exam. And we're going to talk about an exam in about next slide. We're going to talk about the exam. But you can do a full knee exam, and you can also do a gait analysis, or as much as you can. You can watch her walk. If she's able to bear weight, that makes you feel pretty good. But if she's limping, or if she can't bear weight, or if she's walking and her knee's bent and she can't straighten it all the way, that's going to give you a lot of information. So keep that in mind. And then you might get some testing on her. My office, not literally, in the space where I see patients, but inside the building, I have some x-ray capabilities. So I can get some x-rays if I want to. I can do some procedures, and we're going to talk about that too. So here's that history I was telling you about. So you ask, acute versus chronic. Is it one-sided or is it both? Did it swell? Was it worse with activity or prolonged sitting? And these are things that you would ask anybody. Now, we know our patient got hurt kind of playing basketball, but I just wanted to give you what a full history would look like for somebody like this. And then there's those mechanical symptoms. Did she have any giving or locking or catching? So you've kind of taken a very detailed history. You've gotten the whole story. So you feel pretty comfortable moving on from here. So what does your physical exam look like? Well, your first thing you do is you do observation. You just take a look. You can see clearly in this picture here that her left knee is about twice the size of her right knee. I mean, you can see the contours of her kneecap in her right side. You can see where like that little dimpling on the outside, but on her left knee, you can't see anything. It looks like a big water balloon. So you see the swelling in there. You know that, what an effusion is that means there's swelling inside the joint. If there was just swelling in soft tissue, we sometimes call that, a swollen, but an effusion means that there's fluid inside the joint. Going back to your history, you thought to yourself, okay, she told you that, this swelled about a half hour after she got home. So if you think about the anatomy again, you know that the knee has got what's called a capsule or a synovium. And that's like a water balloon that helps kind of keep the fluid inside the knee. So if something's going to swell, if it starts to swell up in the joint, it's got to fill that space up first, and then it starts to get large enough where you can see it through the skin. So a lot of times a delayed effusion, a delayed swollen joint is because it has to fill up the joint itself. So now you're thinking, okay, there's something wrong with the joint. It's probably not something on the outside. It's not something like a muscle or a tendon. This is something probably joint related. She's got tenderness along the joint line. Now, the joint line is where the bones come together. That's the joint. And she's got tenderness right along that joint line. Her motion, she's got, she's able to bend her knee and straighten it, but she's got what's called a positive Lockman. Now, a Lockman is what we call a special test. And this is a test that's specific to knee problems. And if you study medicine, you're going to realize there's lots of test names out there, and they're usually named after, doctors or surgeons or people who founded them and found them to be useful. And there was a Dr. Lockman who kind of coined this test. And what it looks like is this. You take a person's knee and you stabilize their thigh. So you're holding just above their knee, where on this picture here, this model where their left hand is. And then you're taking your right hand on their tibia, on their shin bone, and you're pulling it as if you're pulling it kind of straight up, like you're pulling a drawer out. And what's happening there is you're looking for motion. You're looking for a gliding motion. You're looking for the tibia to translate on the femur. It's like if you're sliding it out. And what you're checking for there is you're seeing if there's what we call laxity or looseness, where it's able to translate. And that would tell you if maybe they injured their anterior cruciate ligament. You could do it backwards. You could check to see if they injured their posterior cruciate. There's other tests that we do. It's called the anterior drawer, the posterior drawer, where instead of trying to support the person's weight of their leg in your hands, you can have them bend their knee up to 90 degrees and have their foot flat on the table and do the same motion. There's tests you could do, which are kind of like doing like a seesaw test, where you're looking to test the medial collateral ligament and the lateral collateral ligament to see if they injured the ligaments that stabilize the inside and the outside of the joint. But all that together starts to give you a picture of what's going on. Typically by this point, you have a pretty good idea of what the diagnosis is. But now you have to prove it. Now you have to make sure you're right. So how are you going to make sure you're right? Well, you might get some tests. So why don't you order some x-rays? So you order these x-rays, and since they're right in your office, you get the x-rays and they come right back and you can take a look at them. And what you have here is, this is a typical set of x-rays that we get for somebody who in their knee. You know, what you have is you have the first one there. That's an anterior to posterior view. It's looking at through somebody as if you're looking at the front of their leg. You can see that their thigh bone, their shin bone, you have that little fibula bone. That's the bone, that's the skinny little bone on the outside of your leg. That's not part of the knee joint per se, but that's a bone that we look at. And then you can see right behind the thigh bone, that circle, that's the patella. The image right next to it, that's called a lateral view, because it's showing you the side of their knee. The reason why we do that is you never want to take a look at a bone in 2 dimensions. You always want to get at least 2 images, so that way you can triangulate. You can actually get a 3-dimensional picture, because certain things can maybe not show up on one image, or maybe if it's overlying, or if there's a bone overlying it, it might not come up clearly, or it may not look so bad on one image, but if you see it in another image, you can see that maybe it's displaced, or it's further away than it should be. So we always check x-rays in at least 2 different planes. You never want to look at one flat image. And then the third image, this is kind of a unique image. This is called a sunrise view. And what happened here is we took a patient and we bend their knee and we shoot the camera down their knee. And it's called a sunrise because that's the kneecap, and it looks like it's rising up over a mountain. It's actually rising up over their femur. And what that does is that allows you to see how the kneecap is sitting in the joint of the femur. So there's 3 different views you look at. Now, the benefit of doing this is it allows you to see the images with your own eyes as compared to just reading the report. So I always look at my own images, and I look at this and I say, okay, I don't see anything, I don't see anything that looks broken. There's no bones jutting out anywhere. I'm also looking for some indirect things. Like you can sometimes see if there's a big pocket of swelling or fluid. You can sometimes see a blackened area, which is fluid. I don't see a blackened area. So even though she had a pretty big effusion on exam, it's not like it's seeped out into the soft tissue. So this is probably still inside the joint. I'm not seeing anything else indirect. So I'm pretty happy with the x-ray. So that gives me some comfort. At this point, I start to formulate what my differential diagnosis would be. And I've mentioned some of these terms, but let's review real quick here. So I already talked to you about the ligaments. And if you injure a ligament, we call that a sprain. Ligaments get sprained. Tendons and muscles get strained. And you see that a couple down below it. So you can see it's either a sprain or a strain I'm thinking about. Fracture is still on my list, but very unlikely at this point. I got a normal looking x-ray, so that's probably not the case. We talked a lot about the meniscus. So people can tear their meniscus. Like you tear a ligament, you can tear a meniscus. The third thing on the list is called an osteochondral defect. That goes back to that cartilage discussion. So this is the articular cartilage, where this is like if you're driving down the road and you hit a pothole. Sometimes people can put a pothole in their cartilage of a joint. And that can become really problematic. Sometimes dealing with that, it's not enough, it's not acute pain, but it becomes a chronic problem. And then the last thing there is a patellar dislocation. Now that's an interesting one, because a patellar dislocation, you could get a patella that'll pop out. It can pop back in again. We call that a subluxation. But you can have that happen. And it's not like a shoulder where, shoulder goes out and you can see it. Sometimes a kneecap will go out, it'll go back in, and it can happen so fast that a person may not even have noticed. But they can be incredibly painful. It causes a lot of swelling. It causes a really specific thing. It's called a hemarthrosis. And that's a swelling where there's blood and blood inside the fluid. So when you take that fluid off, it comes out bloody. And only a couple things do that. So that's one of the things you can think about. But these are kind of what's going through my head right now. So I'm thinking, maybe a ligament, maybe a muscle, cartilage. Well, let's see. How else? What can I do to get more information? I need more. Well, here's something I can do. I can do this right in my office right now. Is I could stick a needle in this person's knee. And I do a lot of these. I do a lot of injections. And I do injections to make people feel more comfortable. But I also do a lot of aspirations because that helps me diagnose a problem, but it also helps for discomfort. If you take fluid out of a joint, if it's not supposed to be there, it can be very irritating. It can be very uncomfortable. And a lot of times sucking that fluid out will make a person feel a lot more comfortable. So what I can do is I can stick a needle in somebody's knee. I draw the fluid out. And in our individual, our athlete, it came back bloody. And I just told you that a dislocation can give you a bloody effusion, but two other things can give you a bloody effusion as well. If you break something, you have a fracture, that can give you an effusion. Bones have a really rich blood supply. So if you see a blood in your syringe, you think about maybe they've fractured something, maybe they have a broken bone. The other thing that can do it is a ligament tear. A ligament tear can give you a lot of bleeding as well. So at this point, my differential just got a lot shorter. Now I'm thinking, okay, this is probably either a dislocation, a ligament tear or sprain, or a fracture. So there's kind of my differential. So I've already chopped off those three, and I'm thinking more of the other three. I cross fracture off because, the fracture, the x-ray kind of helped cure that for me. So that's a little bit lower on my list. Now, meniscal tears can also give you bleeding too, but also that's still on my list because the mechanism is still bothering me. She twisted, she rotated. A lot of times twisting, rotational, they can take out a meniscus as well. So now I have to talk to the athlete. I'm like, all right, what are we going to do? Well, we should probably do one more thing, and then I'll be at my diagnosis. I think it's one thing. And if you were asking me right now, I'm really thinking about that ligament because the mechanism, the looseness on her exam, the blood in the syringe, I'm thinking ligament, but I want to prove it to her. So I'm going to refer the patient for an MRI at this point. I'm going to get the patient an MRI so that way I can evaluate the rest of the tissues. X-rays don't show MRI. I need something that's going to show me soft tissue, and a ligament is soft tissue. To protect her, because I know she's having some instability because that she can't really walk all that great, I'm going to put her in a brace that's going to allow her to be a little bit more stable. And that's typically why we use braces. We don't use braces for any other reason. Braces are meant to help with stabilization. I'm going to give her a medication to try to help with some of that swelling because that's miserable. She's going to swell back up again if we don't give her something to help with that. I'm going to wrap her in an ACE wrap. I'm going to put some ice on her, and I'm going to get the MRI, and I'm going to see her back. So I got my MRI. So this is what an MRI looks like normally. So there's different images that you can get, and I'm not going to run you through an entire MRI because there's usually about, 50 images that come in an MRI. But this is the important one for what I'm looking at here. Now, if you remember when we talked about the x-rays, I talked about this is a lateral view. What you can see is this is the femur, this is the tibia, and this right here is the kneecap. So this is, you're looking at somebody from right to left. Bones look good. This thing right here, this black strip right here, that's the ACL. That's what it should look like on somebody. And these things back here, these gray things, these are muscles. That's what muscles look like. So this is a normal MRI. So you have that in your mind. This is what you got of your person, your athlete. So here's the bone. They look all right. Muscles look pretty good. Well, look what's missing. That ACL is missing. That ACL is missing is because this individual, she tore her ACL. She had an ACL tear. And this is a very common thing that we see in basketball players, unfortunately. And we see them in non-contact. So this individual, this young lady, she was bringing the ball up. And when she rotated and her foot was planted and she tore her ACL. And that's what happened to her. So now you have your diagnosis. So you give her the news. Your differential diagnosis is down to 1. And, it confirmed what you thought. So you used your special test to confirm your diagnosis, and now you've nailed it. So now what are you going to do about it? Now you got to fix it. So you give her the diagnosis, and you go through some options with her. We can send you to a surgeon. Now, you're not a surgeon. I'm not a surgeon. So, you're me at this point. So, you can't do surgery on her, but you have colleagues, you have friends who can do surgery. So you can use that. You can do physical therapy. Not every ACL needs to be surgically repaired. Now, it depends on the situation, and we make that as a collective team often. In a young person, we often do repair the ACL, especially somebody who is planning on being active and maybe playing basketball again. And then we talk about, do we want to brace? And there's a role for all 3 of these. A lot of people at this age will go through surgery. There are some people who will attempt to fix this without surgery, and that's perfectly reasonable. The literature supports that. Sometimes we even do therapy to get somebody stronger before surgery. This is not something that needs immediate surgery. This is not an emergency. We could delay surgery for a month, 2 months, whatever, as long as you want. Especially if they were missing motion and they didn't have full motion, you could delay surgery. Bracing, we can brace as needed to protect them. And then we can brace them a little bit afterwards. Now, gone are the days when we would brace people long-term. We don't do that often anymore, but bracing has a role as well. Our athlete opted for surgery, and this is what the surgery looks like. Now, I'm not a surgeon, so I can't walk you through the whole surgery, but I can tell you what this individual had is she had what's called an arthroscopic surgery. They do it through 3 or 4 little tiny holes in the knee and cameras. And what they do is they poke a couple holes in you. One of these has a camera on, the other one all have your instruments, and you can actually do a repair without cutting a big incision in the knee. And we do that on purpose because it speeds up the recovery, and it's less chance of somebody having a bad outcome like an infection or some other problem afterwards. So this is a way to do a minimally invasive surgery. You go through surgery, and then after surgery, you start therapy. And we play a role here too. We sometimes interact with the physical therapist who's doing it. There's so many protocols out there, so this is a very well-organized thing. They do strengthening training. We try to get their quadriceps and their hamstrings on an even ratio. We work on flexibility. We work on something that's called proprioception. And proprioception is that's kind of where your body's ability is to know where it is in space. So that way, hopefully you don't trip over, you don't stumble. We rebuild the balance so that way your body can adjust to differing terrains and do things. Do we brace? Here's that question again. So no evidence that pain, range of motion, graft stability, proprioception, or subsequent injury were affected by brace use. So anymore, we don't brace routinely anymore. Like I said, sometimes we brace people prior. Sometimes if someone's in a certain situation, or maybe they've had a couple injuries, we might consider it, but anymore, we don't go right to routine bracing. So bracing is not something that we reach for right away. Here's your physical therapist working with your athlete, working on her knee. Her knee's recovering. They're working on motion here. They're trying to get back that full motion. You want to be able to get the full extension, full flexion. Make sure you can walk, make sure you can run, and you can do everything you want to do. At this point, your role as a sports medicine doctor is you get to help kind of with some of the return to play decisions. When is she able to go back? Now, Mother Nature has its course, and Mother Nature will heal at a certain rate. But you also get to evaluate, and you can use some of your clues, like how strong she is, or how strong her left knee is compared to her right knee, and taking a look at that objective data to help make a decision. You also get to help care for the patient as far as their mental health. So you're already doing their physical health, but sometimes injuries can be pretty debilitating to athletes as far as what does it do to them. They get a little bit isolated because they're not part of the team sometimes. Sometimes they're off in the training room doing rehab and they're not part of the team. Sometimes they might get pretty depressed because they can't play the sport that they love. So your job is to maintain and work with and make sure they keep their mental health the same. You also help with nutrition. And you might interface with a nutritionist, or you could design a nutritional plan to get that person all the nutrients they need, where maybe they need less calories because they're not working out as much, but maybe they need more protein so that way they can protect their muscles. So you get to design a nutrition plan for them. And finally, you get to help them with an exercise prescription And maybe that exercise prescription is also away from her knee. Maybe you're having her do a lot of upper body exercises. So that way, as soon as her knee is ready to go, she can get back into activity and she's not going to be out of shape and delayed. They have arm bikes. They have different things that you could do where you can still get a cardiovascular workout without using your legs. So that's a great way to help train somebody, get them back involved in athletics, maybe not, while they're trying to protect and rehabilitate their knee. This individual, she did great. You did your job. She did her job. She had a full return to sports and she was ready to go next basketball season. Typically for an ACL, you're talking, a couple months. Usually it's about, 6 to 8 months recovery. So if she got hurt, in the middle end of the season, that will give her plenty of time to get back in time for the beginning of the next season. And usually they make it back and they come back and they do great. So in your case, your athlete did awesome and she returned to full sports. A couple of things that we also think about. So she comes to you and she might say, hey, how do I prevent me from hurting my other knee? Or maybe her teammates or maybe the coach is like, God, that was a killer losing our star basketball player. How do we prevent this from happening again? And the one thing is with ACLs, there's lots of theories. A lot of them are not actually, they don't hold water. But the one that you do know is that there is something that's involved with proprioceptive and neuromuscular training. And what this is this is how our bodies react to different extreme things. So the one thing that we know is that women tend to tear more ACLs than guys. And by watching them and watching their mechanics, we realize that they decelerate in a different fashion. So if they're running and they have to come to a stop, what we do know is that men sometimes they come to a little more of a gradual stop, or women, they stop all of a sudden. And that stopping all of a sudden puts that shearing force. So that's one thing that we work on retraining. The other thing is when women tend to make turns, men tend to round their turns. They kind of go wider. Women cut sharper and they turn much quicker. So what we do is we know that turning motion, that pivoting motion also puts them at risk. And then the other thing is sometimes it's a little bit about strength and how do you control. That's the neuromuscular part, is the brain muscle connection here. So we work on good strengthening and how to train the body so the impulses and the control over the muscles are better. And that's a couple of things that we do for prevention. So there's actually preventative courses out there where a team can do certain exercises before they practice, which can help train for this and prevent people from getting hurt more frequently. So with that, I've kind of walked you through a typical episode covering everything that I get to do when I take care of an athlete. And it's pretty much applicable across. And, a lot of those things are not just about a basketball player athlete. Those things I also do if I'm taking care of somebody with arthritis. I go through a lot of the same stuff. The history is the same. The evaluation is the same. The images are the same. The injections are the same. So this is very applicable, but this is typically what I do. So I'll take a breath. Dr. Smith, I don't know if you want to open up for questions or however you want to, do you want me to sign? Do you want me to jump off of the sharing screen here at this point, or what do you want me to do?
You can jump off the screen if you like, but you can leave that there too. It's totally fine.
Okay.
We do have a couple questions in the chat. The first one is, how do you know the patient didn't lie about pain level to get back onto the field? If the patient is so passionate about the game and doesn't want to leave, how can you tell if they're lying?
Yeah, that's a great question. And I'll tell you, I love athletes that push me to get back. It's so much more fun to take care of somebody like that than I have to push somebody back. How you can do this is I don't base my return to play on just the questions alone. I use objective findings that they can't fake. So in our situation here of our basketball player, what I would have done is say she had full motion and say she was able to bite down and maybe not have so much pain. I would have got her up and walked her. And if she walked okay, I would have run her. And if she ran okay, I would have made her jump. And honestly, if that injury was there, she would not have been able to do half of those things. So her story she might say one thing, but the story I'm getting from her findings are telling me a whole different piece. So that happens. And I don't get upset when athletes try to do their craft. That's what they're supposed to do. And it's hard. It's hard for me to tell somebody no. A lot of people will tell you that's the easiest thing to do, is to say no. It's easy to tell, no, you can't do that. But you know what? They're coming to you because they want to do something, and your job is to help them do it, but to do it safely. So you use all your clues and you can get to the bottom of it. So they can lie, you still figure it out.
What kind of nutrition would you prescribe for this athlete during her recovery process?
Yeah, so in this one here, I would definitely decrease her caloric intake because she will not be burning the same level of calories. What you can do is you can actually figure out, there's a thing, it's called the basal metabolic rate. And that's how many calories she needs to take in if she's just sitting around doing nothing. So you can start there. And then you can, if she's doing some rehab, you can figure out what it is. You don't want her to lose muscle mass. So you don't want to cut her calories dramatically, but you don't want her to get fat or overweight, where then she's got to lose the weight so she can exercise. So you cut her calories. Because you're trying to repair tissue, you want to make sure her protein is appropriate. Protein is the building block, and that's what's going to allow her to heal. So you want to push her protein. You don't have to get crazy. You don't have to give her, tons of protein, but you want to make sure that she's getting protein, probably about at least 1 gram per kilogram would be helpful. And then, you want to make sure she has plenty of water. So I would decrease calories, increase protein.
Okay. Do you ever have to work with nerve damage, permanent or otherwise?
Sure. Yeah, I see a lot of nerve issues. And permanent's a problem. Nerves are incredibly resilient and much more resilient than you would probably think. I see a lot of nerve problems related to neck and low back problems. Nerves are interesting. So the nerve, the cord is covered in a tissue. It's called myelin, which is fat. And what happens is the nerve message, it doesn't go down a nerve like a linear train. It actually jumps down the cord. It jumps. And so a lot of times when people have nerve damage, what happens is they injure the myelin. They compress it, or maybe they squeeze it, or they bruise it. And that's what interrupts the message, and that's what disrupts the message. So we see a lot of them. If you don't transect a nerve, if you don't cut a nerve, and even if you cut a nerve, it sometimes can be fixed. But if you insult a nerve, there are a lot of things you can do to try to let it heal. A lot of times it needs time, and you got to give it time, and you have to be patient with it, and you protect it. There are certain medications that we can prescribe that help with nerve-related pain while the nerve's recovering. And then there's exercises you could do to help retrain the muscles around the nerve, so that way the nerve has an easier job. So I see a lot of nerve-related injuries, and we work with them. I mean, carpal tunnel is a nerve-related injury. I see a lot of carpal tunnel. I see a lot of neck stuff. Like I told you, low back stuff.
Is the treatment plan similar for arms versus legs?
Can be. The joints, if you look at the body, your hips kind of like your shoulder, your knees kind of like your elbow, your ankles kind of like your wrist. Now that's a completely simplified, and I'm not trying to insult you, but if you think about it that way, a lot of them can be very, very similar. Now the joints, your knee and your elbow works very similar. They're like hinge joints. They open and they close. So a lot of the rehab can be very, very similar. Little things, little tweaks are different though. It's interesting. The elbow is such a weird joint. It gets so stiff so fast. So we are very aggressive with mobilizing people in their elbow, especially the older they get. Younger people, kids, their elbows, we can put them in a cast and they'll be fine. If we cast an adult, if we cast them for 2 weeks, their elbow gets so stiff that sometimes recovering from the stiffness of the elbow is worse than the elbow injury itself. So we mobilize them quicker. So in all essence, the anatomy is similar. The principles are the same, but we tweak the rehab a little bit depending on what joint we're dealing with.
Okay. Have you ever had to do sports medicine with a swimmer?
Oh, I see lots of swimmers. Swimmers are awesome. I see, it's funny. I see swimmers because a lot of times because of shoulder problems. You don't get a lot of acute swimmer problems. Swimmers have some interesting medical things though. Swimming, lots of people will have asthma and exercise-induced asthma from swimming because of the chemicals. But why I laugh off the top is because I work with a guy who the majority of swimmers get hurt when they do things outside of the pool, when they're doing dry land activities. So we say swimmers are better when they're in the water. And so, when they're in the water, they're usually okay. They get hurt in the weight room and stuff like that when they're on dry land or when they're running and they're doing stuff. But if they're in the pool, it's usually overused shoulder problems. I see quite a few shoulder problems just from the wear and tear.
I will keep that in mind the next time I go swimming. Are there good exercises for women who are aging to keep their knees strong and healthy? Someone once told the question asker, a knee cushion is like the tread of a tire, and when it's gone, it's gone.
Yeah. So, women, one of the things I've actually lectured on women and knee pain a lot, and it's a super prevalent issue. Women will often get anterior knee pain. And a lot of it's for a couple different reasons. Some of it's biomechanical. If you look at how a woman is built, women are built a little bit differently than men. They typically have a little bit wider hip ratio. And what it does is it becomes a physics problem. And if you look, and if your hips are a little bit wider than your knees, and if you put your knees together, you can see how that creates a sharp angle. And then what happens is the physics, it wants to push your kneecap to the outside. So then your kneecap ends up rubbing on your femur and it can wear away some of that cartilage. Once cartilage is worn, it does not come back and we cannot regrow cartilage. We have not figured that out yet. If we figure that out one day, we will essentially have solved arthritis. We have cured arthritis. It would be like the holy grail. It would be amazing. Now we're getting better, but what I tell people to do is to protect yourself, flexibility, critically important to make sure you keep stretching. But the other thing you can do is strengthen. It's critically important to strengthen both your thigh muscles, but your hip muscles as well. Because what that does is that keeps your knees from wanting to push to the outside, from gliding to the outside. Simple things you could do, wall squats, lunges, things like that. You don't have to do, serious weight training. And the one exercise I tell everyone to stay away from, especially women, and especially women once they're, 40s, 50s, 60s, 70s, 80s, is the one when you go to the gym and you sit down and you have your knees and you have to swing them outward. The knee extension machine, you should avoid. That puts a lot of pressure on the knee joint. I'd rather you do leg press or squats or anything else because that actually dissipates the forces over more joints. Stay away from the knee extension machine.
I do. I don't like that one. Why would the doctor order an MRI rather than getting, why couldn't the doctor order an MRI rather than getting the x-ray first and then the MRI?
So that's a little game. That's a great question. So, two reasons. Number one reason is it's important to make sure you don't miss a fracture. MRIs are not great at ruling out fractures. Yes, you can see the bones on an MRI, but they're not the best. And a fracture, you don't want to miss a fracture because that can get a little bit dicey if you miss a fracture and it's not repaired. So you want to make sure you don't miss a fracture. The other thing is it's a dramatically cheaper test. So we do x-rays often first before we get an MRI, just to make sure if that's the answer, it can end right there. So that most places you have to get an x-ray first just to evaluate the bones and make sure you're not missing something. Honestly, MRIs, we overuse MRIs. We don't need to get as many MRIs as we get. We need it as a confirmatory test, but honestly, your exam and your x-rays can give you a whole bunch of information. MRI should probably be saved if you're thinking about a high-grade injury that needs to go to surgery.
Next question is sports medicine a good thing to learn for someone wanting to become a chiropractor?
To become a what?
Chiropractor.
A chiropractor. There's actually some crossover there. When I told you guys from the top of the talk as an osteopath, I use my hands. So I do manipulation that like a chiropractor would do. But the important thing is, chiropractors are all about understanding anatomy, and they understand the anatomy as well as I understand the anatomy. And we actually share patients sometimes. Like I have a patient that if I have somebody who has a back that needs to be adjusted, I can use a chiropractor to help me get maybe a rotational component fixed and straightened out. So do you need to do it? No, it would help you because it would give you an insight. So understanding, anatomy, physiology, mechanics, things like that would help you. And those are things you would learn from sports. It's not a prerequisite, but it would give you some assistance.
How long was your residency and your fellowship?
Residency was 3 years. Fellowship was 1 year. So medical school is 4 years. And then I did 3 years of family medicine and 1 year of sports medicine.
How closely do you work with orthopedic surgeons? And is there a reason you didn't go that route?
Yeah, so I work very closely with them. I have a lot of, besides having a lot of friends, we share a lot of patients. So I talk to an orthopedic surgeon routinely, and I'm going back and forth with them. I decided not to be a surgeon because it's a little longer training. I don't know how much longer, but the residency is at least another year, and their fellowships are, especially if you decide to specialize in fellowships, those are usually another year or two. I had a career before I went to medical school, so I was already getting a little bit further along. I did not want to, I like to have different types of relationships with my patients. Part of the reason I went to family medicine was to have a little more of a continuity relationship and actually see them longer term. So that was part of the other reason I went to family medicine and sports medicine. And then honestly, my legs get tired from standing too long. So I didn't want to stand in the OR all that long. So I don't know, I'm tired.
I like that reason. What's the exact difference between an MD and a DO?
So there's a philosophical difference and there's a training difference. Years and years and years ago, there was a lot of differences, but it comes down to two things. They're trained identical. They have the same level of training. They do the exact same things. I have partners who are MDs. I have colleagues who are DOs. We all do the same thing. The difference in philosophy is that osteopaths look at things as the entire body is interrelated. So if you get pain in your ankle, it's because maybe there's something wrong in your back. At this point, I think that most MDs or most allopaths will also look for the root cause. So I think that philosophical difference does not really hold water, but that's what we're trained. So there's a philosophical difference that we try to trace everything back and we think everything's interrelated, but I think that allopaths do as well. The only other difference is that I can use my hands, so I can do what a chiropractor does. We don't adjust. I do what's called osteopathic manipulation. So I can actually feel with my hands if a body segment is rotated or out of alignment, and I can use my hands to put them back into alignment. So I can do like a maneuver, like a popping maneuver, or I can do a maneuver where I hold somebody and I stretch them until I get a release. So that's pretty much the only difference nowadays. We're licensed the same. The schooling is the same. The exams are the same. They actually had just recently rolled over where allopaths and osteopaths do the same type of training. So it's the same.
Okay. Clearly your specialty in the field of surgery interact, but what information is exchanged and to what extent does your jurisdiction stop and you can't decide what's best for the athlete anymore?
Yeah, I mean, they overlap almost completely. The only difference is that I feel that my jurisdiction stops when we start talking about surgical procedures. Now, I know a lot of surgical procedures. I've watched a lot of surgical procedures. I've been in on a lot of cases, but I feel that I'm not doing the case. So I shouldn't probably go. I should let the surgeon, because I don't want to set the patient up for something and then the surgeon to do something completely different, because I feel that could potentially harm the relationship. I can tell that, hey, I can tell a patient, this injury it looks, it doesn't look great. I don't think it's going to heal well without surgery. I think you should talk to a surgeon. I'm totally comfortable doing that. I'm totally comfortable telling them, that I would seek a surgical opinion. But as far as the medicine, the benefit is then they can go over and kind of talk through what the surgical options are. The one limitation is if I try something and say something is broken and I try to fix it non-surgically, which a lot of fractures we do, but not every fracture heals that way. The surgeon has the luxury of being able to say, you know what, this didn't heal. We're going to go in and we're going to fix it by plating it back together again or whatever. So they do have that additional benefit. We have usually very open lines of communication. Lots of surgeons' practices employ people like me, and they cross over. Surgeons will often send people like me injections to do under ultrasound guidance. That's the one thing I didn't go into but we do what's called a lot of ultrasound guided procedures where I will use an ultrasound and I can guide a needle to where I want it to go. It takes a little bit of time. So sometimes a surgeon will send a case like that to me because their day might not be set up for that, but I can do that in my office. There are certain things that I handle that surgeons don't. Like a lot of surgeons don't handle concussions. I tend to handle a little bit more of the medical side. And that's one of the other things that attracted me to sports is over orthopedic surgery is I like exercise-induced asthma, or I like commotio cordis, or I like, I don't like commotio cordis, but I like treating people like that. I like vocal cord dysfunction. I like dealing with the medical side of sports medicine, not just what breaks sports medicine.
You talked about experimenting with athletes to see if they can get back on the field or back to a routine faster. How can you tell the difference between safely speeding the recovery process and rushing the athlete back?
It's a good question. I'd lie to you if I told you that sometimes you try something and it backfires. Sometimes you try to get pretty aggressive. You enter it with full transparency. You tell the athlete, and everyone's fully aware. Now you don't ever make a decision that's going to permanently harm somebody or it's going to do damage. Maybe it ends up costing them like a couple of days. Maybe they get sore, or maybe they're a little more swollen because you pushed them too hard. But sometimes you need to push somebody and to see what the outcome is, to know where the line is and how far you can go. There are certain things that you cannot rush. So there are certain parameters you work with. I mean, I can't take somebody with a broken arm and expect them to be fixed in 2 weeks. It just does not happen. Mother Nature will not allow that. Bones take 6 to 8 weeks to heal, regardless of what I do, special. But I might try 6 weeks instead of waiting to 8 weeks. I might, start to mobilize them a little bit earlier and maybe get their fingers moving a little bit, knowing that they might be less stiff, but do it in a very controlled fashion. So there are some risk reward, but you're not talking about like risking somebody, where they get hurt again, like bad. Like you don't do that. But sometimes you push a little bit and then you realize, all right, we pushed it a little too much. They're going to be sore the next day. We might have to, ice them down, or we might have to give them a medication or something like that. But that's all about, that's the art of medicine is understanding how you, and you learn that along the way, and you learn how aggressive you can be. There are people who are incredibly aggressive, too aggressive. And there are people who are incredibly conservative and too conservative. You try to find that happy medium. And you also sometimes flex one way or the other, depending on your athlete. Sometimes people, they're very cautious and they want somebody who's going to be cautious with them. Sometimes you're like, hey, I can stick you. We've all watched, the NFL, and you see somebody come out with a big giant club on their arm. That's an aggressive push. What they've done is they've built a brace to protect somebody so they can be back on the field, but they won't re-hurt themselves. That's being aggressive.
Right. Sebastian, I believe you have a question. I'm going to go ahead and ask you to unmute and you can ask your question.
Yeah, I was just going to ask, so I just want to introduce myself. I'm Sebastian. Thank you, doctor, for the lesson. You guys can call me Seabass. And I just really interested in like contemporary and like jazz dance. And like, I was just wondering, like, can you just be a doctor and just focus on like dance injuries and stuff like that, or no?
See, Bass, man, that question is music to my ears, not to be completely profound there as far as dancing. So I just hired my partner, my new partner. Her specialty is dance medicine. So she takes care of everybody else too. She takes care of arthritis and knee sprains and ankle sprains, but her passion is dance and performing artist medicine. She's trained in New York. She worked with athletes and dancers and performing artists up in New York. And now she's brought her craft down to us in Delaware. And she's going to help me build out an entire, offering that's related to dance and dance medicine and performing artists, because those are some of the greatest athletes in the world, and they get hurt like crazy. And you need somebody who can take care of them. And it gives you a tremendous amount of buy-in if you can speak the language and you know what they're talking about. So when you ask them like a position that they get into that hurts, if you know what they're talking about, or you can actually ask them, it's amazing how that builds the relationship almost instantaneous. So you can absolutely do that. I have one. I get to work with one all the time, and she's amazing.
Fantastic. Next question. Since fluid is needed in the knee, is there ever a reason to return the same fluid that is removed?
Yeah. So there is absolutely fluid in every joint. And there's a certain amount of, we call it a physiological amount of fluid in every joint. We don't typically put fluid back into the knee that we took out, because that would probably be pretty irritating. We put a lot of other things in knees, like we put steroids, we put lubricating injections called, visco supplementation. We will sometimes we take blood out of a person and we spin it down to get the platelets. Then we inject that back into somebody's joint. We don't typically put fluid back in. Your body has this ability to produce it over and over and over and over and over again. So I don't need to put it back in, because the body will put itself back in. It'll put its own fluid back in the joint that you took out.
Question about COVID. How has COVID impacted your medical specialty's ability to diagnose and treat sports injuries by telehealth?
So that's another great question. I kind of told them. So I'm very involved in telehealth. I do a lot of telehealth. It's interesting. I feel that my field is one that really is helpful to have hands-on. And there is a component where you need to actually touch somebody. So in the beginning, when COVID first started and we were only seeing people virtually, it was a challenge. But I'll tell you, and I started this off when I started talking about, the diagnosis, a good history can give you almost the answer. So not every time, sometimes you do need to see people, but we did okay in the beginning with COVID and our ability to diagnose people and treat them. We had to be a little more conservative. We had to order probably a few more tests, because we didn't have the luxury of putting our hands in somebody and maybe feeling that joint laxity or feeling how they were moving. Nowadays, it's super easy to do, because the telehealth visit, if there's something I want to touch, I can bring them in for a follow-up visit. We still do a lot of telehealth because I can interact with you right now. I could get your whole history. I could be like, yeah, that really sounds like that person may have torn their ACL.
Right.
Why don't you come and see me next Tuesday?
When I was 15 getting my arthroscopic knee surgery, that history, yeah.
Exactly. But I could be like, why don't you come in and you could get your x-rays before you come and see me. So what I do is I end up making your second visit that much more productive, because I have a head start on the visit. So yeah.
Excluding paralysis or some other severe life change, is there any injury that even a young athlete can never come back from?
Oh. I can't think of anything, because, what is your, and I'm not trying to play, what is your definition of come back? Come back to exactly where you were before? Sure, that's a lot. but to come back in any capacity or come back and do anything or do something, most people can adapt and do something. I mean, look at how many athletes, even people who do get paralyzed, if they get maybe only their legs get paralyzed, they become wheelchair athletes. There are ways to do something, and there's hardly a reason to keep people out of doing something to stay physically active. Even if it's just riding a bike or going for a walk or doing some weight training, almost everybody can do something.
So we've got time for a couple more questions, and I'm going to be picky and choosy, but Dr. Sandella, what we've been doing for our previous speakers is any question that we don't get to, I'll send you, and then you can take your time and write an answer to those questions, if that's okay? Okay. Awesome.
Perfect.
So one question that came up is, how can somebody make an appointment with you to see you?
So, I work at Christiana, so to see me, I'm a little tougher to see because I actually have some other responsibilities. So I'm a little more difficult, but my partners are phenomenal. But I still see patients over at Wilmington. We have a phone number. We have access on the Christiana homepage. So I mean, if you want it that specific, I could get that information to you. But I work at Christiana, and we're Christiana. It's called ChristianaCare Sports and Lifestyle Medicine is our practice. And I told you I have 3 amazing partners who have much better availability. They've restricted me because I get to work with our specialty programs and our virtual programs. So I don't see a lot of patients anymore, but I miss it. So, but please, if you want, let me know. I would be more than happy to see you.
All right, last question, because I had a couple people interested in it. Have you ever diagnosed Lyme disease from the fluid removed from a joint?
Yes, but I'll tell you what, that's not the best way to diagnose Lyme disease. I'm sorry to tell you. You can absolutely diagnose it, and you would think it would be from the fluid in the knee. But if you look at and read the evidence, it's actually better to diagnose it from a blood test. And you can do it from either. You could do it from blood or from fluid in a joint. But yes, I have, and yes, I have.
Fabulous. Well, thank you very much, Dr. Sandella. We have loved having you. I have like 20 more questions that are going to come to your way.
Oh my God, like homework.
I know. You didn't know this is what you were getting into, did you?
I did not, but I'd be happy to do it.
Yeah. Everybody, thank you again for coming today. Next week, week 4, we're going to be speaking with Dr. Patel, who's going to discuss with us the growth of telehealth and the virtual experience. So stay tuned, and we will see you next week. Thank you again, Dr. Sandella.
Thank you.